I'd like to have you join me in welcoming Dr. Laura Gilcrease to the stage to open the ceremony.
Well, good morning, everyone. It's great to see your smiling faces, and we have a spectacular speaker this morning. As John said, my name is Laura Gilcrease, and I'm the CEO of Alberta Innovates. On behalf of Dr. Chris McCabe, the CEO of the Institute of Health Economics, and myself, I'd like to welcome you to the 18th installment of the Alberta Innovates IHE Health Policy Speaker Series. We have a group of folks here, meaningful folks here this morning in this room, but we're also live streaming this event, so I'd like to extend greetings to those of you who are online. Alberta Innovates has a mandate to support research and innovation in Alberta and working with our partners to diversify Alberta's economy and enhance the well-being of Albertans, and I want to emphasize the well-being of Albertans. A key priority and program area for Alberta Innovates is the health sector, and we are very pleased with many of the partners in the health ecosystem, including IHE that's here today. This is an ongoing policy series that provides a valuable opportunity to bring the Alberta health community together, to listen, to learn, and to reflect on perspectives from public and private sector thought leaders. Of course, I have to add my own comments here beyond my notes, which is, and to take action, please. That's very important to me. I have the privilege of being able to introduce and welcome back to Alberta our guest speaker today, Omar Ishrak, the Global Chairman and CEO of Medtronic. You all have the biography information in your packages of information, so I'll not repeat that, but encourage you to read it. Omar has a fascinating background and evolution, someone who has achieved a lot, not just in his personal life, but for others. It's interesting to see the progress of an electrical engineer through progressive positions of leadership to a global CEO of a $30 billion US dollar company. Put this in perspective, from my perspective, a market cap this morning of over $120 billion, and you compare that to our oil sands that produce $150 billion a year. That gives you an idea of the achievement of this gentleman. So, as a company operating, Medtronic operating in 150 companies, it's not often we have a global CEO of his stature to visit this province. Omar, you bring to us a unique perspective, I'm sure, and on a regular basis, you look at the mosaic of different systems and the emerging patterns that come from this vantage point. Omar has asked, we would like to share a small video before we start this presentation this morning, so if I can ask that video be played. as you can see, Medtronic and its leadership team make a difference in either your lives or someone you know. So please join me in giving a big welcome to Omar Ishrak.
Thank you very much, Laura, for that very kind introduction. And you know, that video is a reflection of the stature and the skill and the dedication of our Canada team, actually. And you can see that we're dedicated to Canada, and Neil himself and his entire team have really taken us to a point where we're a truly credible partner with authorities across Canada, and a real believer in this country, and an ability to make a difference in healthcare, and learn as well from our experiences here. So it's a place that you know, I've come to fairly often. Actually, we come typically once a year. I think I missed 1 year, not quite. I think I came here in the winter of last year as well, and it's always very intriguing. And I'll talk about that in my comments here in a few minutes. So let me start with a little bit about Canada, like I was starting off with in my opening comments. You know, it's a single-payer system, as we all know, but it's an interesting single-payer system because, in fact, you have several single-payer systems within the country. These different single-payer systems are concentrated around your different provinces. And the provinces are of different population sizes, and some fairly small, others a little bigger, but all kind of small compared to a global context. What that does actually is it gives us an ability to have enough of a population, even in the smaller provinces with 1 million some people, enough of a population to get scale results, and yet a small enough number of stakeholders with whom we can work effectively. It's similar to working with a small company versus a big company. And in a big company, often you have to struggle, like I do, with a lot of people, having to herd cats, and it's not easy to move the ship sometimes. And there are techniques through which you do that, but it does take longer. A smaller company can move more quickly. And in that way, a province, which is relatively small, in fact, can try new things more effectively than others. The other thing about Canada, and I'll go through the rest of this, which are more the issues that Canada faces, but if I focus on the advantages of this country, the other thing that you have here is a connection with the US, which I think is pretty important. From a clinical perspective, it gives a level of scale beyond the country itself, in terms of clinical trials, in terms of information exchange, in terms of simply physician exchange, which is really quite seamless between universities and institutions in the US and Canada. And I think that gives you access and a connection with the highest levels of healthcare technology and healthcare thinking in the world. So you've got a very high-end kind of mindset around healthcare, and at the same time, you've got a small enough base where you can effect a difference. So that excites us a lot, and that's why I'm so interested myself in coming here and spending time with the different provincial stakeholders and see what we can do together. Now, the problems are there, and we will talk about how we address some of these problems. But if nothing is done about healthcare, then you will get this. You'll get longer waiting times because there's not unlimited money. And if all you do is limit the budgets, then the only variable to adjust is the waiting time. Because, you know, what else are you going to do? You just don't have enough money, so you make people wait. The other alternative is to spend more money. And that, at some point, has a limit as well. And in addition to the longer waiting times, the other thing that a limited cost will do is it'll inappropriately limit innovation, but it'll simply cut out the most expensive areas of technology which are apparently expensive in the short term, but which may have higher returns. You know, you won't even have time to think about that stuff. So innovation will get hampered if you don't do something about this. So I think from Canada's perspective, it is important that we deal with the healthcare. And I do think you have certain advantages through which you can be a leading voice and a leader in the development of new forms of healthcare for all the reasons that I just said. Now, why is Medtronic interested in value-based healthcare? Because that's essentially what we'll talk about today. And you can easily ask that question. That why is a company which makes medical technology, why does it matter so much to us? It matters because the mission of this company is very clear, and it's something that was written in 1960 and hasn't changed since. And I'd argue that one of the main reasons why we've had success over the last 50 years or more is because the leaders of this company, generations of leaders of this company, have stuck to this mission, both from an inspirational perspective, which it clearly is if you read it, but also from a strategic perspective, which is more nuanced, but it is equally important. And so let me describe that to you. What does the mission say? It says that we're a biomedical engineering, we use biomedical engineering, so we're a technology company. That's the core of this company. We live in technology, and I'll talk about that in a few minutes. But we don't finish with technology. We say that the technology that we invent has to alleviate pain, restore health, or extend life, which at first sort of reading seems like an inspirational statement which sort of binds together all our employees in a common purpose and all of that stuff, which is all good and important. And it does have a big impact on the culture of this company. But buried in there is also a statement which says, in the end, that we're a technology company focused on changing outcomes. And that is not an option. It is required by our mission, and that then translates to a very clear strategy. So when we invest in things, every time we ask the question, what is the line of sight to changing an outcome from that investment? It's not only, here's a cool technology and it's new stuff and let's go do it and then we'll figure it out. Right from the very beginning, the question becomes, how are you going to change an outcome with this technology, and what do you need to change the outcome? And I'll talk more about that. So I'll give you some background as to why value-based healthcare is important. It's because value is outcomes over cost, and outcomes is core to this company. So that's why value-based healthcare for us is important, and more of it will come out in the subsequent slides here. So let me first start with the technology, though, because we have a certain type of technology that we focus on. And as you can see, there's a variety of different clinical areas, all the way from cardiology to neuroscience to diabetes to surgical tools. In all of those areas, we have technology. Equally, we have technology, and you can also see that it's primarily hospital-based technology. I mean, there are some exceptions, but by and large, these are sort of acute care type of technology. And maybe acute is too strong a word here, but patients with fairly advanced conditions who use our technology. That's the kind of company we are. And the line of sight to an outcome in these are clearly important. The nature of our innovation, however, is in different categories. The vast majority of our spending, in fact, is used in what we call continuous innovation, which continuously updates our technology over time. So in medical technology, as opposed to pharma, that in fact is a possibility which is of real value, because from the first introduction of a new type of device, because of ongoing experience with that device in actual clinical practice, we know how to improve that device in many different ways, from ease of use to actual fit on a patient, to improvements that improve outcomes in some way. We can do continuous innovation. And through that, products that have been released at say, year 1, by year 5 or 6, they're vastly superior and almost unrecognizable, and yet it's happened in a kind of steady sort of fashion, incrementally, as opposed to a direct change. And that's because of the learning that we have as we have more experience with that type of device. And that's what we call continuous innovation, and that goes on forever, and that is something that is essential for our success, and I think it's something that physicians want from us. But equally importantly, the core of this company, and almost all medical technology companies do this, but the core of this company, and what really separates us from others, is that we have a real skill in creating markets, in either creating new markets, which is what we say invention. And you can have examples from everything from transcatheter valves, where others do as well, but we're a primary contributor in creating that market, to things like stroke treatment, through the Solitaire product or the pill cam, which is a device through which you can do a colonoscopy by a camera that you essentially swallow. I mean, these are new markets that we create through our technology. Creating a new market is not easy. You need clinical evidence, you need to publish, you need to convince physicians, you need to get reimbursement for it to be a real market. Any one of those alone will not do the trick. The technology alone will not do the trick. Evidence alone will not do the trick. Publications alone will not do the trick. Reimbursement obviously won't happen until you do all of those. But all of those things are essential. And then you need to go and sell it, broadcast it, commercialize it. I mean, these things require a certain skill set, and the company knows how to do this. So we know how to create new markets. Equally, we know how to disrupt these markets, which I think is pretty rare, certainly amongst companies our size, and you don't often find it because people get enamored with their size and the markets that they're in, and they try to protect their position in those markets as opposed to go out and actually disrupt them. Medtronic, however, has a history of disrupting our own markets. And the best example we have of that is, in fact, the technology through which the company was invented or started, which is the pacemaker. The company was started through the invention of a battery-powered portable pacemaker. Prior to that, pacemakers were plugged into a wall, and therefore it had its limitations and really was not an ongoing treatment device. A battery-powered pacemaker made it portable, and that was how the company started. Eventually, it became an implantable device. That was a disruption. And then most recently, when that world thought that the cardiac rhythm devices which were implanted had essentially matured, and there's not much you could do with that technology, we recently introduced a disruptive device, which is a transcatheter-based pacemaker, and eventually other cardiac rhythm devices which are inserted through a catheter. And there are no leads. That's a disruption of that market, which creates new growth areas in that whole market, which was considered mature. There are other markets that we can disrupt as well. We disrupted the market for paroxysmal AF treatment through the introduction of the cryo balloon as a treatment, where previously it was all done through RF ablation. Here was a treatment which has had excellent results in the treatment of paroxysmal AF. And again, it's a market and a technology that we use to disrupt an existing AF market. We've got ideas around hemodialysis that we think we can disrupt that market. So disrupting markets and creating new markets is what separates this company. Other companies can do continuous innovation, but there's very few companies who know how to create and disrupt markets, especially disrupt your own market. And it's something that really is at the core of Medtronic. However, in an ongoing basis, like I mentioned, the creation of a market is simply not the invention of technology and the clinical data. Associated with it is the payment model. And historically, that's been reimbursement. Going forward, just reimbursement alone is not enough, because reimbursement is done with macroeconomic factors in mind. And as healthcare grows and becomes more complex, we have to translate economic value to true budgets in healthcare systems. And that's the only way in which new technology can be afforded, if people can see how their budgets, which they can measure and be accountable for, gets impacted through the value of the clinical value that's created from this new technology. And so this focus on economic value that we actually started 4 or 5 years ago, sort of preempting the move to value-based healthcare, because we felt that without that understanding of economic value, we will be stuck in a position where people won't buy our products and we won't be able to get reimbursement for everything, because macroeconomic factors, after a while, it's just going to go over people's heads, because it doesn't affect their budgets, and the Treasury Department couldn't care less about macroeconomics. They want to see, what's my budget? And so, we had to cross that bridge. And we started to think about it, and that's the core of our thinking around value-based healthcare. So it's a translation of the technology to clinical value and eventually to economic value, which is the core of value-based healthcare, which is where we start this journey. Now, we've talked a lot about value-based healthcare, and again, going back to what I've been talking about, why is it so important to make a change? Because in today's world, and in our own example, our business model is geared around selling a technology with a promise to change an outcome. Like I've mentioned several times, it's a credible promise based on publications and acceptance and real data. But it is a promise. And there are many variables which are associated with reaching that outcome, some of which are separate from the device itself. And yet the promise that is made from which reimbursement was obtained assumed that everything else would fall in line. And if everything else doesn't fall in line and the outcomes aren't reached, guess what? You pay again because the patient probably comes back for something else. And so if you magnify that approach and sort of stretch it across the entire healthcare system and everything that we do, not only from a technology perspective, but from a service perspective in terms of the fees that a physician gets or a hospital gets, all of which are based on promises to change outcomes instead of being actually accountable for the outcome, then you'll get a system that has high risk, and in fact it's happened, of getting escalating and uncontrollable cost increases because you're spending money on things you never budgeted for because the reimbursement system didn't assume that half the patients wouldn't take their drugs that are associated with getting to an outcome that they'd assumed, and things like that, or other such problems. The other thing about a fee-for-service system is that it puts the patient at the lowest end of the priority scale. Because the patient, in a fee-for-service system, the patient pays for the service. Whether it's out of pocket, or whether it's through taxes or insurance or whatever, in the end, the patient pays. And yet, they have no promise that they'll actually get something for the payment. They'll just pay. It's just like me buying a TV set, and if the TV set goes wrong, I just will go buy another TV set. Well, that's not going to happen. I'm going to go return the TV set and ask my money back. And I can't do that. A patient doesn't do that. If there's a mistake in the system, whether it's intended or not, no one cares, except them. And they're the lowest in the priority scale. So we want to shift to a system which is a fee-for-value system where patients are at the highest end of the values of the priority scale, where the system gets paid only when outcomes that are meaningful for patients are actually achieved. And so a fee-for-value system makes us accountable for the outcome as opposed to simply promise that outcome from the technology that we produce. So it's in many ways, it's a simple change. In text, it's changed from promise to accountable. It's a massive change to the healthcare system. A massive change that not only impacts us, but more than that, it cannot be realized without everyone else being aligned along the same direction, because we will not be accountable for an outcome if other stakeholders who have a say in the outcome are also not accountable for it, because we just cannot do that. We can't be accountable for something and then someone else sort of messes something up and we're accountable for it. So that clearly doesn't work. So this has led us to increasing our window through which we talk to others. We have relationships with peers, we have relationships with other companies, and understanding of other technologies which are beyond the therapy itself into areas all of which can impact an outcome. From patient behavior to discharge instructions to physician skill, all of that becomes part of things that we have to understand. Not necessarily own, but understand. And so that is what the change is to become to go to a fee-for-value system. And I think many of you who are providers in the room, you can all kind of think through this and see how your world also changes as you move from a fee-for-service sort of system to a fee-for-value system. Now, I've sort of interchanged the words outcome and value quite a bit, so let me be clear about what the difference is. Outcome is an outcome that's meaningful to a patient. That means a patient feels better in some way, or doesn't feel worse. That is an outcome too. Or gets worse, which is a bad outcome, but is an outcome. The cost required to achieve that outcome is another parameter that has to be monitored. And the value is actually the outcomes for the cost. So the cost required to reach a certain outcome and an improvement to that ratio is the value that's created. So that's what value is, and so again, I'll tend to sort of interchange value and outcome a little bit, but I hope you understand the difference here. Now, as we've tried to operationalize value-based healthcare, which again is a simple high-level concept, but as you try to put it in place in healthcare, you come across all the differences in healthcare and all the issues in healthcare. One starts to kind of think about this, and some of these statements are almost obvious, but it's amazing to see that even for us, we're to actually think about it and write it down before and sort of grade them as to their importance in a journey to value-based healthcare. And the most important element in a journey to value-based healthcare is the ability to define and measure an outcome and the cost associated with reaching that outcome. Let me repeat that. To define and measure. Define means you need to be clear about what it is. What is the outcome that you're looking for? And that cannot be a subjective statement. It needs to be a clear statement that this is the outcome that we're looking for, that we're going to measure. And then you've got to have a measurement system through which you can retrospectively baseline that outcome. Otherwise, you won't have a starting point. And then you have to prospectively monitor that outcome in the future, so you can look at the difference between the starting point, which is the baseline, and the future, which is the prospective monitoring. And the future improvement should be obtained by some sort of intervention. And in our case, that intervention is a technology intervention. So that's how you measure the value of a technology. How did the outcome over cost change over time from a certain baseline? And you can see from those words that unless you clearly define the outcome and have clear means through which you can measure it, don't even bother starting the journey. So don't talk about fancy business models and all this other stuff till you know what you're talking about here. And the moment you start with this perspective, it tells you that value-based healthcare is a granular exercise. You know, outcomes in general sense, you can talk about it, but the variables are so many that you won't be able to deal with it. So value-based healthcare has to start in a granular fashion. Disease by disease, category by category, which leads me to the second point, which is that even when you measured the outcome and defined it, the nature of that outcome will vary according to the cohort that you select for a given disease state. For cardiac surgery or some other kind of surgery, the care pathway that you will put in place and the eventual outcome that you will realize will be different whether you're treating an elderly patient with multiple comorbidities versus a young patient with no comorbidities. It's the same disease, the same procedure, but you will treat that patient differently. It's a different cohort, and physicians do this. That's how they risk assess patients. But you have to realize that when you do that, there's a different cost and a different outcome expectation. And if you blend the two, you might decide that someone is expensive and doesn't do their work right, when in fact they have a different cohort. And they should be paid more, not less. And they shouldn't expect a better outcome because that's all you can expect. And you cannot confuse these factors. So having very specific cohorts and a clear understanding of those cohorts and data which identifies those cohorts is essential to a journey in value-based healthcare. And the third aspect that one then has to come to, which is kind of obvious, is that, well, what are the different variables and how complex is it to actually take a certain cohort and achieve a certain outcome? That means what is needed? Is it just technology, which is the simplest case, fairly rare, but does exist? Or is it also the skill of the physician, the skill of the nursing, the discharge instructions, the patient adherence, the socioeconomic factors that a patient is under? Which of those factors are relevant in achieving an outcome? And if there's many factors, I'd say that that's a complex case, in which case you need an agreement that has everyone aligned, all the different stakeholders aligned. Or there could be a simpler case where only a few variables are involved with. So thinking around these three factors, the clarity of an outcome, the clarity of the cohort, and the number of variables that are required to tie the two together are essential elements in operationalizing value-based healthcare. And so if you look at healthcare, it's also important in that context to think about, what is healthcare and how does one look at it? And if you leave prevention aside, it's really chronic disease management and episodic care. And chronic disease management is the management of a patient who has a disease, whose condition you want to prevent escalation. Any real escalation can create an episode of care, an intervention, which is called an episode. But by and large, in chronic care management, you have continuous monitoring of the outcome of that patient, and you want to ensure that that patient never really escalates to a degree. And the quality and the value that's generated is how much of an improvement I can make from a baseline in that patient's health or outcome, or if that's the same, then how low a cost can can I have in maintaining that outcome? That's the value creation in chronic management. In addition to that, if there's an escalation of that process and you go into an episode, then it becomes a very high cost affair. And an episode is different because in an episode, not only is it higher cost, but what an episode has, it has a different kind of outcome measure. It has an outcome measure that actually has three factors. One is it's a very limited time window. An episode starts and finishes. You do something you expect to finish. The patient is recovered from that intervention and actually has an improvement to their health status based on the intervention that was done. And so in an outcome measure for an episode, one has to then have a projected outcome from the planning that was done on that patient. Now that exists. No physician's ever going to do a procedure without at least having an expectation as to what to get. And so you can define that based on the cohort and so on. But equally, you have to have an outcome measure that takes into account the recovery process, complications, inadvertent issues that may arise, infections, other things that may arise, which was caused by the procedure itself and the patient didn't have when they walked in. So the recovery process is also a measure of that outcome, which doesn't exist in the chronic care world. And I say all this to make sure that you understand that these are two different worlds, and the costs are different, the way you manage them is different. The other thing that we're increasingly learning is that the primary stakeholder in the episodic care world is actually the physician, while in the chronic care world, it's actually the patient themselves who can decide whether to follow a care pathway or not without anyone saying anything. While in the episodic care world, I think the physician has a lot more control. So these are things that we're learning, and it's important to think of healthcare in terms of the chronic care management and episodic care, while appreciating that there's a connection between them. But avoiding episodes is actually a huge cost savings. And once an episode is done, sort of doing it properly with the lowest possible cost has a big impact if you do it right. So we've got different programs. We're working both on episodic care and on chronic care. In episodic care, we've got our areas of focus right now, amongst others, are a cabbage procedure and some joint procedures. In chronic care, which I'll talk about more, we've got a variety of different things, all the way from sort of comorbidity management, which is the closest link to population health comorbidity management through remote patient monitoring. We've got very focused chronic care in very focused cohorts. In pediatric type 1 diabetes, where it's a very specific condition, but it's a chronic condition. And you need a very specific type of care pathway to manage those patients, which is different from managing comorbidities in a general population. We've got areas of very high level type 2 diabetes, which could be a subset of the comorbidity management. In some instances, that could be separated out too. And then we've got obesity management, which is a very particular condition where we engage in both the bariatric procedure, the surgery, as well as ongoing monitoring of that patient over a 5-year period, reaching certain outcomes. So that's chronic care management and episodic care management. The other one that I want to touch on, where we've had the most success, are actually areas where the technology and the outcome are directly linked with no other variables. In both the examples that I stated earlier, in episodic care and chronic care, in all of those examples, we alone through our technology cannot get the outcome. We need somebody else. We need the physician, we need the patient adherence, and all the other areas that we talked about. However, in terms of therapy optimization, we've got a number of models where you put a technology into either an episode, primarily an episode, but sometimes in chronic care, where the technology itself, without any other intervention, gives a favored outcome. And the best example we have of that is the first one on the left, which is Tyrex, which is an antibacterial sleeve we put on implantable devices. And if you put that sleeve on, we will guarantee that that patient does not get an infection. Now, we've learned how to do that, and the difference between the importance of cohorts became obvious because at first thought, our inclination is put this on everybody. Well, if you put it on everybody, you're putting it on people who will never get an infection anyway, and although the outcome doesn't change, the cost just went up. So from a value perspective, you really don't get an improvement. To get a value improvement there, you've got to understand the cohort. And if you do put it on patients who have high risk, you actually get a reduction in infection, which has a real financial return. And that taught us, in a simple example, that to do value-based healthcare of our natural inclination that if somebody wants our product, sell it, is not always the right thing to do if you're really measured on value as opposed to the number of sales that you make. And I can go through many examples like that you can run into in many different scenarios. So, I think I won't spend too much time on this because of, I see the clock ticking here, but essentially, I've talked to all of this, that in value-based healthcare, you need data, you need to start to think about things in a systematic fashion, although the programs themselves are different, they're granular. But perhaps the most important point I want to make in this page is item 3. You will never do value-based healthcare unless physicians buy into the process themselves. Value-based healthcare is simply an extension of the way physicians are trained to do their work, using data, using risk assessment, using outcomes. No physician is trained to do anything unless they understand outcomes. What do they do? To improve people's health, that's an outcome. But we've never operationalized it. We've never systematized it. We've never used data rigorously to do that. And we've got to get physicians to do that, to not change their thinking, but to improve their thinking with data and with a structured approach to outcomes and cost. And I think that is the most important thing in this page. And then if you do that right, and you have enough data, the VBHE procurement processes also need to be developed depending on your healthcare system. Now, I'll spend a few minutes on data here because it's important. And we're learning more and more about this, that to affect value-based healthcare, our understanding of data is extremely important. And data will come in different forms. It's real physical data, which is in many ways real-time data that we get, or EMR data, that's clinical data from patients, which is like medical quality data. You've got behavioral data that comes from all kinds of different sources, from your activity to, tech companies have video data, which look at facial expressions, to your sweat, to your temperature, to, all kinds of different things, which are sort of not strictly clinical, but behavioral data that can assist in understanding a patient's condition, especially in chronic care management. And then you have data science, which takes all this data, uses artificial intelligence to come up with algorithms, and machine learning to continue to improve those algorithms, and more on a personalized basis, but there can be other uses of machine learning too. And so there's a variety of uses of data, but this chart kind of depicts how important data is to our future. This is our attempt at organizing that thought process. The most important point is on this page is the outcomes management platform. That's the platform where data is collected and action taken. And data is collected from patients, that's behavioral data, from real-time data from the patient, which is what we call a foundry, which is, in our case, our data, linked with EMR data from hospitals and primary care and other medical institutions, and then claims data from the payer. You link all of that together, and the outcomes management platform analyzes all that data to continuously improve your outcome at the lowest possible cost. That structure, which this is sort of attempting to create, is the structure that we've got to do. Let's not oversimplify this, because what you need to change the outcome and monitor the outcome is a different thread, maybe using the same data, from an action that provides personal insights and alerts to a patient, which is then different from something that provides insights and alerts to a physician to manage the patient. In all these situations, you use this kind of framework, but the output is completely different. The language through which we will send an alert to a physician to manage a patient is different from the language that we will use to send to a patient to manage themselves. And it's certainly different from the sort of data we need to come to a conclusion regarding a clinical trial. And you've got to be really careful with this. They can all use the same sources, but the outputs are dramatically different. And you've got to understand it in that fashion. So we're only scratching the surface and ourselves learning how to use data, but we're rapidly understanding that this is a critical area of development for healthcare, and one that will formulate itself into different disciplines over time. An example here, which I'll actually conclude with, is our effort at population management. And we've learned that through data, and now not necessarily clinical data, but behavioral data from patients, we've found methods through which we can actually analyze a high-risk population and determine which segment of that population will be responsive to remote patient monitoring. Not everybody is. And that's not only clinical. It's clinical as well as socioeconomic, as to which patients will respond to remote patient monitoring. Whether they can, touch the buttons or not touch the buttons makes a difference. And so that's one sort of discipline that we're establishing. And that allows us to select the right patients to do remote patient monitoring with. And then we use data to send alerts to physicians to take the right action based on the alerts. And those alerts can be pretty sophisticated artificial intelligence, which collects real-time data plus behavioral data from the patient to send out risk categories to physicians saying that watch out for this patient, or saying that this patient is complaining, but really there's nothing wrong. And then you have to take the appropriate action, which the physician then has to take on the patient, or some caregiver has to take. So the right clinical action, the right patient at the right time is what has to be done through this process. And you can see how data is used in this particular situation. And clinical data is not the only thing here. Behavioral data in many ways is more important, or equally important. Real-time data plus logged-in data plus a verification process, all of which is involved in creating a model for chronic management for patients with remote patient monitoring. We're doing this type of program around the world. I'll pivot to that, and there's many examples of that in Canada, certainly a place that we're particularly interested in. We're going on a journey in Canada in many of these areas where we're focused on. St. John's is a place where we're actually beginning to do episodic care, where we're managing a hospital department there, cardiology, and from which we'll create value-based models for episodic care. And in the end, I'll finish with what we started with, that everything that I talked about here today are things that you can see the complexity. You cannot just go to China and say adopt value-based healthcare and think they'll know what to do. It's not that easy. There's 1 billion people there with all kinds of different things to do. It's a single-payer system, but it's 1 billion people. Instead, let's come here to Alberta with 4 million people. And I think I got a manageable thing here where people can sort of, at least we can have a discussion around these topics in a way in which we can actually decide on some action on a very limited pool and learn from that and get physicians on board and change their behavior. And I'm not changing the behavior of 2,000 or 10,000 physicians. I'm perhaps changing the behavior of 100 or sometimes even less. I mean, that's doable. And so this is the opportunity that I see in Canada. Sort of small enough to manage, yet big enough to carry weight and scale in what we learn. And advanced enough in thinking that we can have this dialogue around the difference between clinical trials and cohorts and all of that. These are natural because physicians have been educated in that way. And so that's what excites us about Canada. And that's really all I have to say here. Thank you very much for listening to me here, and more importantly, coming here to listen and for all your interest in this subject. And you can clearly see that it's something that we're passionate about, something that we're determined to make a change, and we think is vital not only for us, but for healthcare. So thank you all very much. Thank you.
Thank you, Omar, for that tour de force of a talk. Really fascinating. I normally go to a talk and I think I'll maybe make 1 or 2 notes. I've written down 12 distinct things that made me think about how we do healthcare in this province and more broadly. So thank you very much. I'm really glad to be able to say that Omar has made available some time for questions. So if people would raise their hands, I will deliver a mic this side. My colleague John Spool's got a microphone over there, and we've got about 20 minutes for questions.
Okay, please.
You going there?
I applaud what Medtronic is doing in trying to define what value-based healthcare is, trying to define what it is and how you measure it. But it must be frustrating from a corporate standpoint, though, that you go through this exercise and yet in some jurisdictions, some provinces, they define value-based healthcare as the lowest price provider. And then whilst you're in the process of trying to define what value-based healthcare, they award contracts based on the lowest price. Is that frustration something that would make you walk away from a jurisdiction or an area in which you're pursuing value-based healthcare and helping work with that province?
Well, that depends on Neil, because he's the one who kind of decides that. As long as he hits his numbers, I couldn't care less whether he walks away or not. Okay. But no, in principle, we don't give up that easily. We're pretty persuasive, and there are different stakeholders that we kind of go after. But obviously, look, there's a limit to everything. If there's a certain stakeholder who's simply not interested, we can play in the low price game too. We'll come up with products which have less value, and because they're not valuing it in that way, and we'll play that game as well. But that's not the future of healthcare. And so that transaction in that province does not become a strategic partner for us. But anyone who buys devices is someone that we cannot walk away from, and we have to understand what their interests are and what their language is, and we'll respond accordingly. But in this journey, they get kind of at the bottom of the list in terms of our dialogue, because they're not interested. So that's the way we'd approach it.
Yeah, part of the challenge is that some people define value-based health.
I know it's cost. Yeah,
As cost.
And then we can explain that, and and if they don't get it, then we play their game. And so fine, okay, so then we'll work with the physicians and figure out what you guys can afford, and we'll get Neil to find a way to do a deal. But it becomes a tactical relationship at that point. It becomes a tactical relationship at that point, and not a strategic relationship. And we'd be clear about that. We'd tell them that, well, that's what you're looking for. Well, you want to do tactics, we'll do tactics. And we've got enough scale and size that we can do that. But you will not be part of the journey through which we define value-based healthcare, which is a long-term strategy for us, and there are others who want to do that. So that's the way we'd approach it.
Great first question. And next question's here.
Hey, I applaud everything that you've done, and the idea of value-based healthcare is outstanding, and you've done a great job. And to take a company that's been operating at 90% and move it up to 91%, it's very, very difficult. You could have easily driven it down, but you haven't. You bring it up, so good job. My question for you is, when you look at value-based healthcare, do you consider the economic value of the individual when they return to work, or are you just looking at healthcare costs?
I think that's included. The total value is included, and in some instances, the return to work is a very important parameter. In some of the episodic care measures, return to work could be the difference between something having a positive economic value or not. But that is an important parameter which we're looking at. I mean, we're early in this, but it's something in our sort of line of sight as to something we need to do.
So then does that lend itself to like a two-tiered healthcare system where you reach the economy of scales based upon people who can afford and whose economic value is being returned to the economy, and then as you reach those economies of scale, you kind of more so are able to serve more people? Just a weird question.
I didn't quite understand it. Tell me that again. Yeah, why would it be two-tiered?
Well, so let's say we're treating all the physicians first who are providing a great economic value to...
The physicians?
Yeah, let's say we're installing pacemakers or what have you.
Yeah.
And they're providing a great economic value to the whole community.
Yeah.
So if we treat them first, let's say you've got some latest, greatest pacemaker, for example, right?
Yeah.
At a higher cost because it's new cutting-edge technology.
But you're getting the
obviously.
value in the end.
Exactly.
Yeah.
For sure you are. Absolutely
Yeah.
you are.
Yeah.
And then as you reach economies of scale, slowly more and more people become more affordable, and so you have like a
So we lower
diminishing
our
cost.
costs, basically.
Exactly.
Well, I'm not sure that we do it that way because, we'd like to tie that eventual return in some way back to the healthcare system if possible, and therefore be able to afford it. I think, yes, sure, economies of scale will allow greater adoption, and there's a natural thread around that, but we try to have a strategy through which the real value is realized as much as possible. And then, because that is a logical given. In other words, here's money, here's the return, I can demonstrate that. And if someone's getting a return on their money, anyone their head screwed on right, will do that, right? Now, economies of scale can give me further cost reduction, which I can use for a different purpose. So, I can use to do more research or do the next generation or work with the physicians in some way. I mean, there's many ways in which we can use money that's generated because of economies of scale, but to kind of fund people who are unwilling to look at a logical return that makes sense means that there's a failure in our ability to convince them. And so we take that approach first. And well, if all else fails, then your approach is, we'd have to give access. And if that's the only pragmatic way to get to that access, we do it. Okay? Yeah, over there.
Hi, I'm Steve Buick with the College of Physicians and Surgeons, and I agree this is fascinating work, and thank you for coming and describing it. It drives me crazy that a big, sophisticated public health system has to pay you to do it, though. So what I'm interested in, though, I mean, isn't this what what a big, sophisticated public health system should be doing for itself in the first place? I mean, what you're describing is basically an economic model of what we in the public health system call clinical appropriateness. But it's shocking that we're not implementing appropriateness as we should. Mm-hmm. So I'm not sure what the question is for you, but I mean, one question is, realistically, is this a business that you want to be in across the entire public health system, or is it something that you show the system how to do?
No, we show the system
should
how to
do it by itself.
Yeah, but show the system how to do it, but we have to be participants. You know, a system is created, but we have to participate in that because our model also changes. And so for us to help the healthcare systems sort of create this is in our own interest, and because it creates value for the stuff that we invest in, our own technology. And so it's not, no, we have no intention of running a healthcare system. Okay, we have no intention of running hospitals, and that's not our role. Our role is to develop technology. And the reason we're even interested in this topic is because today that technology is not being valued, and we're spending money developing that technology. So that's not a sustainable business model. And so therefore we're pushing this. But our desire here is to convince healthcare authorities and payment authorities to adopt this model because it's in their interest as much as it's in our interest. And I think that's all we're doing. And you could argue that just sit back and let somebody else do all of this, and we could. But our worry with that is the fact that this is in the end our technology and our business model is dependent on appropriate designation of value for the stuff that we invest in, and that's what drives us towards this. And frankly, it makes us develop better products. A discipline around this forces us to think more efficiently about products. I can tell you, this is without any hard data, just intuitive sense. We launched on this economic value thought process, I'd say 6 years ago. And we started by changing our own product development process. Every company has a product development process, and there are things called stage gates where you kind develop a process, and then you go through a review process, you ask questions, and typically these questions are, technology type questions, what's your spec, and does it work, and have you done it right, and all that stuff. But also in the medtech world, clinical questions. Have you tested it clinically? In that stage gate process, we've inserted economic value questions as well. Have you thought about where's the economic value going to reside? Not how you do it, but where is it going to reside? At least understand it. Is this going to reside in quicker back to work? Is it going to reside in less hospitalization? Who's going to get the economic value? At least have that thought process. And we've deployed that. And our business teams have thought about that and have prioritized things that we have line of sight to economic value. And our growth rates and so on have improved as a company, significantly in the last 5 years. And more importantly, our productivity of our engineering has gone up. In other words, things that we launch in the market get scaled results relatively quickly. And I think some of this is a factor. I mean, it's not the only factor. There's many other things that happen there. But I do think that the discipline through which we're choosing the things that we work on is helping us. So, there's more to this than, being a good contributor to the world's healthcare. I mean, it's in our interest as well. And I think through that, we're convincing others as well, or at least that's our desire.
Since I hold the mic, I might ask a kind of question quickly. Yeah. Omar, because you'd mentioned, or Laura mentioned in the opening remarks about you being able to have a vantage point of looking at the mosaic of different systems. And you launched, I know, the last few years, this thrust. Yeah. I know you've mentioned that you've come to some realizations that things don't move sometimes as quickly as you might have anticipated at the beginning of this discussion, which I know you're having around through a variety of jurisdictions. What are some of the key surprises that you've learned over this period of particular journey, of things that are taking longer than you might have expected, or common approaches in different countries, like in the Netherlands or in Europe and the kind of thing, where you say, oh, I didn't anticipate that. That might provide us some lessons of things that really need to work on and be impatiently patient with in terms of driving stuff forward.
You know, I think the thing that has been most surprising in some ways, and one frustrating equally, is actually something that is that's a common factor across all healthcare systems around the world, whether it's a payer or the government, a commercial payer or the government. It's a mistrust of medtech companies and a mistrust of us as to what your motives are. And so I go into healthcare systems and payers, and we go in there and say that, look, we will save you money. We will guarantee the savings of money if you do this. And we will guarantee the savings so you get results this year. If someone came to me with that as a business for one of my suppliers, I'd be all over that. And yet we go to payers and they don't believe us and they don't want to do it and say, show me this and show me that and all this kind of stuff. And that frankly is a surprise and somewhat frustrating, where we're saying that here's a healthcare system complaining all day long, I mean in general, about too much money and all that. And here I am saying that I can guarantee savings for you. And the answer is either I don't trust you, which they don't say directly, or it's too much work. Okay? Well, it's too much work, you're going to get savings. Too much work, it's too small. It's things like that. And I do think that a realization that we've come to the conclusion that value-based healthcare is a granular approach. I don't think everyone understands that. And I do think that and the mistrust is something we got to get over. Maybe the other thing that I'll mention, which is more obvious, and I think I got more sort of consensus around this as a need, is that the world essentially, and the United States is probably the most extreme example. The world's healthcare systems have been built on a fee-for-service model. So there's enormous inertia. And by that I mean stakeholders who have programmed their own business model in a fee-for-service world, and any change is a threat. Even though they will conceptually agree with the concept of value-based healthcare, because it's very difficult to disagree with improving outcomes at lower cost. But they will say, you do it and not me. And then when you do it, then I'll come aboard. The problem with that is that value-based healthcare only works if all stakeholders are aligned to that common goal. You can't have a patient reach an outcome and a physician says, well, I don't care about it. Everything else can follow value-based healthcare, but I get paid no matter what. So and I didn't mean to pick on physicians, this could be anybody. And I think that realization that the fee-for-service system has such inertia, to the degree that there are actually legal barriers. Value-based healthcare does not work unless people work together. There's legal barriers against physicians working with companies, hospitals working with companies, because of anti-kickback regulations, all kinds of other regulations, all there for the right purpose. And I don't think they can be overturned overnight. But at the same time, we need to create safe harbors where sort of convincing and good value-based healthcare models can be adopted in that world fairly easily and not sort of roadblocks one after the other. So I think that's the sort of learning that we've had, the trust and the realization of value and the granularity of how it is, and the legal barriers or the inertia, the three things that I'd pick off on. Okay.
Thank you very much. Unfortunately, we're going to have to wrap up the questions now.
Thank you.
I just want to take this opportunity to thank Omar again, and if we can all express our appreciation, please. I'd like to say thank the people who joined us online. I hope you found it as useful and enriching as I certainly did, and to everyone in the room for making time this morning, and wish you all a great day. Thank you. Bye-bye.